My name is Pablo Kim, vascular surgeon at Mount Sinai Hospital. Is everybody awake? I guess this is the first session on veins. And I know he said the eve of intervention, but I call it the sexiest part of vascular surgery or cardiology or whatever you guys belong to. So I'm going to talk about superficial venous reflux disease option and advancement. I'll tell you what are the current options. 20 years and plus, we used to do a lot of stripping, and there were very little options. And starting in the early 2000s, we started with laser ablation and burning the vein, the trunk of vein, to get rid of varicose vein. And nowadays, we have non-thermal. Things got as easy as injecting crazy glue into veins and making this vein disappear. So it's a very exciting time to treat these patients because there's a lot of treatment modality, and I show you what are the differences. So these are my disclosure. Venous disease affects about 2.5 Americans, and approximately 24 million Americans have varicose vein. It's a very, very prevalent disease. So if you're interested in this, you're going to get a lot of patients, okay? Approximately 20% of them, you have to watch out because a lot of primary care physician tells them it's a cosmetic issue, you don't have to do anything. Well, about 20 to 10% can undergo chronic venous insufficiency, and once that happens, there's nothing you can do, okay? So you have to treat them. If they are severe, I think you have to treat them. And about a small portion of this, there's about 500,000 patients with venous ulceration, which is a very, very debilitating condition. This is the CF classification. C1 is when you treat the patient for most cosmetic issue. I'll show you what I would treat it with sclerotherapy. Is C2 and above is when we start treating patient. When they have a documented reflux with symptoms, C2 and above is when we start treating. This is chronic venous insufficiency, C4 and above. This is when they have severe skin changes. There's so much venous hypertension that you develop a lot of inflammation in the lower leg. And once this happens, you develop lipodermal sclerosis, which is just basically scar tissue formation. There's no cure for this. So if they're severe, please treat them. Vein stripping, I hope nobody's doing this in 2021. A lot of folks started doing non-invasive treatment with laser therapy. Laser therapy is basically getting access on the local anesthesia into the trunk of vein or the gray saphenous. The majority of patients have greater saphenous reflux in 90% or more. And you're basically burning the vein shut at 1,200 degrees after applying tumescent solution, which is basically local anesthesia. RFA is another technique. I call it the tank of endovenous procedure. It's a 7 French catheter. For God's sake, are we doing iliac stenting? So Medtronic actually promised me the next year they may change these and make it into a 6 French, which is kind of exciting, and make the catheter a little bit more flexible. What is the problem with thermal energy or burning veins shut down is that you have to be careful about the nerve. So below the knee, when you treat the gray saphenous vein, you have to watch out for the saphenous nerve. If you damage that, you can get severe numbing sensation. Which is not that bad, but if you globally damage the nerve, you can get shooting pain. That patient will hate you. When you treat the SSP, you have to worry about certain nerve, and if you're really bad and you get too close to the saphenopapillary junction, you can get a foot drop because you can damage the perineal nerve, so you never do that. A lot of still treatment in, I don't want to say India, but in India, there's a lot of presenters that still do a lot of foam sclerotherapy, which can work, but it takes them like 10 times to close something like that into this. Sclerotherapy can be effective, but it can take multiple times, and the yearly patency rate is very high. We want higher closure rate. It's completely different from arterial. Sorry, this is Rasmussen comparing all the different modalities, all the different modalities, laser, RFA, stripping are all very, very efficacious, over 95% closure rate. However, the pain is, of course, is much higher in stripping, so you don't want to do that. The pain in EBLT and RFAs, they're about compatible. Foam sclerotherapy patency rate is about 20%. So not efficacious, but if you do it multiple times, you can close veins. So these are the new kids on the block. Not new kids, they've been around for 10 years, and this is what people thought is going to overtake venous insufficiency treatment because it's so much easier. There's no tumescent, it's very quick. You inject things, or as I said, you can inject crazy glue into patients now. MOCA therapy is a pharmacochemical ablation. The tip rotates at 3,600 RPM, and then you inject foam sclerotherapy. So you're making a 5 millimeter vein, make it spastic into a millimeter, and now you can do sclerotherapy because sclerotherapy works really well on small veins. Some of the research shows that the closure rate is over 95%, which is comparable to RFA or laser therapy with minimal side effect. And patients are shown to have less postoperative pain, early return to normal activity, and this product has been great. We used to do a lot of this. The problem in the U.S., the challenge is that insurance don't pay for a lot of this procedure, and it only accounts for 2% of the procedure that we do in the U.S. This is a Venous, this is glue. This is basically crazy glue from human beings. So basically, you are holding pressure and you're injecting this glue at 3 centimeter segment, and you're shutting down the vein. This has, on the B-Close study, is very compatible to RFA, and is shown to be very efficacious. You just have to know how to pick the patient. I wouldn't pick anybody who has a vein size over a 1.2 centimeter, 1.5, definitely not. Because the rate of thrombophlebitis is a little bit high, it's about 20%, and patients do complain about that. There is different things that I do with this. This is the catheter. You actually can introduce the whole catheter and inject it in different segments, but this is not FDA-approved. This is how I do it. Sometimes I inject it directly, or I inject it with a micropuncture, depending on what the patient needs. And we use that for a lot of venous restoration therapy. Varithena is foam sclerotherapy, but it's compounded foam sclerotherapy. It's twice the dwell time as physician compounded foam. So smaller, more uniform bubbles leads to better closure rate. However, still on the Vantage 2 trial show that the 1-year closure rate is 73%. But on Vantage 1, the symptomatic improvement appearance at 8 weeks are phenomenal. So I think it's all about selecting your patient. I use this a lot for recurrence patients that have already undergone ablation therapy in the above the knee, and we use it for recurrence. If you use it for recurrence, we get very good result with this. This is actually a very good representation of what we are doing in the United States. This is the CMS data of everybody who underwent venous ablation procedure in 2020, and there were about 100,000 patients that underwent with RFA or laser, which is thermal therapy, and there were about half actually with non-thermal therapy. So a lot of physicians are replacing thermal procedures with non-thermal, and this is where we're heading into. Now, this is a patient that I treated with MOCA. She has severe pains, quite large varicose vein, but you could get pretty good result with MOCA therapy. I would have done the same thing with Varithena. If the veins are smaller than 1 centimeter, and you can definitely get good therapy with non-thermal procedures. This is a little bit of a bigger patient that I treated with RFA. There's no staphyloidectomy needed, and you can see her veins are completely gone within 4 weeks. But when you have patients like this, with veins that are measuring 2 centimeters, a lot of times RFA or non-thermal therapy would not be enough. So what this patient underwent was an RFA procedure of the great sapphire vein, followed by staphyloidectomy, and veins are completely gone. Because of time, I'm just going to show you what sclerotherapy means. A lot of time you can inject this with 1% polydiagonal. You don't have to use foam for foam. I use on veins that are bigger than 1 millimeter. This is about less than 1 millimeter, so that you can definitely do just polydiagonal 1%. This is foam. I mix 1 part of air with polydiagonal, and you could actually get pretty good result. This is before and after procedure pictures. Staphyloidectomy is very important because all the veins are not only connected to your truncal vein. Even though you do ablation, the veins are still going to be there. This is a video depicting what staphyloidectomy is. Staphyloidectomy is a very simple procedure where I start with a little local anesthesia, and then I use tumescent. I don't use it. There's no cutting here. I go with it with a sharp 18 needle, and then we use fine instrument hooks, and we just pull them out. Next. Chronic venous insufficiency. This is actually what I really specialize in, and I want to spend a little bit of time at the end. The SCAR study and the EBRA study shows that if you have a patient with ulceration, you have to do a treatment. It decreases the healing rate as well as the recurrence. So we actually, this is the EBRA study. We actually published some of this. I'm just going to go through this because of timing issue. I don't want to be delayed. This is one of my patients that have an ulceration 5 by 10 centimeters for 5 years, and after a couple of MOCA therapy and 4 months of wound care, it completely healed. So these are patients that we actually want to really treat and don't lose. This is one of our paper that we published in JBS, starting to do a lot of this work with non-thermal therapy, and we've been extremely successful. This is with the MOCA therapy that we were able to decrease the healing time by twice when we use this non-thermal therapy. And what we are working currently is with Venous and Bariathena, and we have published some. We haven't published some of this work, but we have presented where we do direct injection into the ulceration. You have this big enlarging perforator, and with a little bit of venous injection, we can close it down. So in conclusion, there's a lot of different modalities that you can use. It's quite exciting to be a vein specialist at this time. I don't see non-thermal therapy replacing thermal. I think there's a role for everything, as I described. A lot of things also, it's not about the safety and the patency of the procedure, but it's also about what the insurance will cover. And sclerotherapy and microphlebectomy are a very important part of the tool because you're going to need that to treat your patient to the fullest. Thank you very much.